I'm Benjamin Levy. I'm an associate professor at the Johns Hopkins School of Medicine, and I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So next generation sequencing is just a fancy word for molecular testing in my mind. It is a way to uncover the genomic underpinnings of a tumor that are then hopefully going to reveal potential alterations that can lead to subsequent treatment decisions. So in lung cancer, we know now that lung cancer can be parsed out into distinct molecular subsets or distinct genetic subsets. These are not genes you're born with. These are somatic genes. These are genes only inherent in the lung cancer. And we know if you have a particular gene of interest, you can be wedded to a particular targeted therapy. And the only way you can find out these days whether you have a particular gene of interest is to do something called next generation sequencing, which is, again, a way to sequence the DNA of the tumor to better understand the genomic alterations of that tumor. And if you have a particular genomic alteration of interest, you can then be wedded to a targeted therapy. To get a little bit detailed, next generation sequencing really looks at several different types of aberrations or abnormalities of genes. It looks at insertions and deletions. It looks at substitutions. It looks at copy number variation, and it looks at rearrangements. And all of these genetic alterations may be relevant in how we make treatment decisions. Importantly, every patient now with advanced non-small cell lung cancer that's an adenocarcinoma, and every patient that is at least not a heavy smoker squamous cell patient population should have next generation sequencing at the very least on their tissue biopsy. This should be done on all patients. I think there'll be some questions about liquid biopsies as well, if you're interviewing me. So there is certainly a role for doing next generation sequencing on tissue and in blood. They are commercially available assays, and there are in-house assays. So in-house meaning that academic centers have their own next generation sequencing platform. But there are also very good commercially available assays that partner with institutions that will run these tests and give you a readout of the genomic underpinnings of a tumor within 14 business days. So it's a pretty remarkable. When I started 10 years ago, there was really no such thing as next generation sequencing. We were just starting to learn about it, but now we know it's really for every single patient with advanced adenocarcinoma of the lung. It may even be relevant in early stage lung cancer, as we've learned about targeted therapies post-surgery or in the adjuvant setting. So that's my 30,000 foot overview of what next generation sequencing is specifically for lung cancer.